Okay, you should now be ready to go.
Thank you. Well, good morning, everybody, and thank you so much for being here. This is sort of quite exciting and unusual for us all, because all of us will have been used to either committee structure of council or a purely cabinet system. So this is something that's new to all of us, this hybrid model of governance. And the executive advisory panels are absolutely vital to us making sure that our members are engaged and involved in helping us to develop policy and to fulfill our plans. So thank you so much for wanting to be put on this panel. I think you're all very, very wise. Health, well-being and vulnerable people is, of course, absolutely vital, and I think that this is, of course, the best panel to be on. I'm a little biased. I'm delighted to be chairing this meeting as the executive member for Adults' Health and Wellbeing. And I think once we've taken apologies, we'll perhaps just go around the room and all introduce ourselves to each other, because most of us know each other, but it's always nice to just make sure everybody does know who everybody else is. So if we can go to apologies, Francesca.
We have apologies from Councillor Shaplock.
Okay, lovely. So if we can go around the room, if we start with Councillor Ken Harrington.
Ken Harrington. I've been a councillor for 30 years. I am president of the Royal British Legion, Wellingborough and District. Hence my link to this, really, I guess, because we do get involved with servicemen, ex-servicemen that have fallen by the wayside, mental health issues and homelessness. Thank you.
Thanks, Ken. Councillor Russell Roberts.
Thank you. Yeah, I'm a Barton Seagrave parish councillor and obviously a Northamptonshire councillor. I used to lead the Kettering Borough Council, and whilst leading Kettering Borough Council, I always, and I think with a modicum of success, reached out to other councils like Corby, and we did an awful lot of work with the local strategic partnership, which was a Labour initiative, but we turned it into Kettering Futures Partnership, where all of the voluntary sector as well as the strategic partners came together and focused on what was really the community's issues. And so I jumped at the chance of being on this committee to hopefully carry some of that work forward.
Brilliant.
I'm here.
Thanks, Councillor Roberts. Councillor Chrissy Smith-Haynes.
Thank you, Helen. Well, I've been a borough councillor and a county councillor. I represent Burton and Broughton ward, but in my professional life, I was a social worker working in adults, primarily with learning disabilities and mental disorder. But I've done lots of work with addiction counselling, for example, and some work with older persons placements as well. So yeah, this is a board that's right in my heart. I'm really passionate about, and so you might see me get a bit emotional every now and again, but there you go.
No, I'm in that.
Thanks, Councillor Smith-Haynes. Councillor John McGee.
Good morning, thank you. I'm Councillor John McGee from Kingswood Division in Corby, and I've been a councillor for over 20 years. I've been involved in our local health forums for a considerable time and chair that. Even at Northamptonshire County Council, I was heavily involved in our communities and health, and I hope we can all address the inequalities and health issues across North Northamptonshire.
Thank you, Councillor McGee. Councillor King-Lewell.
Hi, yes, my name's, as you know, Councillor King-Lewell. I own an adult social care company, been running it for, well, the company's been running for just under a decade, and my involvement has been about 6 years, this adult social care company stretches across the Midlands, namely Hertfordshire, so I've got a contact and experience there in adult social care services, in addition to that's Bedfordshire and Northamptonshire. So I guess what I'll be bringing to the table is my knowledge and understanding of the social care industry. But in addition to that, I'm also trustee of Groundwork Northamptonshire, which runs the likes of the Green Patch. So in terms of wellbeing green initiatives, again, I am very passionate about both social care and health and wellbeing. So I also represent Queensway and Brickhill, that's my ward.
Thanks, Councillor Well. Francesca.
Hello, Francesca McHugo, and I am the Democratic Services Officer who will be responsible for this panel.
Thanks, Francesca. I don't know if Charlie Christmas can hear us.
Yes, I can. Apologies for no camera. I'm Democratic Services Officer and I support Francesca with this panel.
Thanks, Charlie. And David Watts.
Morning, everyone. Hopefully you all know me by now, but I'm David Watts. I'm the Executive Director for Adults, Communities and Wellbeing. I'm a social worker by background, but I've also worked in direct care as well. So my first job in social care was as a relief care assistant, and I've worked my way up over those years. My portfolio, I will go in to explain a little bit more about, but you will see that the large majority of what sits in my portfolio of work will be of interest to this executive advisory panel. So I'm really looking forward to getting to know you and introducing you to other key members of my management team over the coming meetings over the next year plus.
Thanks so much, David. And I haven't really exactly introduced myself. Obviously, you know that I'm the portfolio holder for adults, health and wellbeing. My background is that I'm a chartered physiotherapist. So I've worked in both the NHS and private care and ran my own business. Health and wellbeing has been part of everything I've endeavoured to achieve for people and for myself my whole life. And so this is, of course, something that I'm absolutely thrilled to have been given the job to do. And I think from our introductions, we've got a really strong team here. I think that we can do some really good stuff over the next year and beyond. And I'm really, really looking forward to working with you all. And I think that we're going to have some great discussions and hopefully contribute to improving services for people across our areas and making lives better, which I think is why all of us are here and why all of us do the jobs we do. So thank you so much. And I will now move on to members' declarations of interest. Are there any declarations of interest today? Chrissy, sorry, Councillor Smith-Haynes.
I'm quite happy with Chrissy, thank you. Yes, just as we're talking about trusteeships, I'm a trustee with accommodation concern in Kettering.
Thanks. And Councillor Lowell.
Yes, so whether this is an interest or not, but as I mentioned before, referred to, I do own an adult social care company. In addition to that, I'm trustee of Groundwork Northamptonshire, which is a health and wellbeing green initiative, climate change organisation, a charity. Thank you.
Thank you. So if we can now move on to the terms of reference, which you will all have received and hopefully been able to have a look through and consider. I'm going to pass over to David Watts to take us through those. So without any further ado, David.
Okay, so what I will do is I will just share my screen so that we have these in front of us. I think probably for our first meeting, it would be really helpful if we do just run through and do a bit of a page turn of the terms of reference, just so we are clear about the roles and responsibilities of different contributors to this executive advisory panel. So hopefully, and just give me a thumbs up, one of you, if you can see the terms of reference. Brilliant, thank you all. Okay, So these are a standard set of terms of reference that are being used for each of the executive advisory panels. So they are standard across all of the panels that we have, and I will also just mention some of the other panels when we come to the end, just because there may be some cross-cutting agendas which don't necessarily fit neatly into one executive advisory panel. And that is one of the discussions that I would like to have today about how we deal with any of those issues which are perhaps cross-cutting. So I will pick that up moving forward. The first page really sets out how we have established the executive advisory panels and the key role of an executive member chairing the executive advisory panel. That doesn't mean that other executive portfolio leads would not have an interest in what this panel is doing. And there is an opportunity for them to attend an EAP meeting and hear the discussions. And as it is an advisory panel, I think I would hope that we would absolutely encourage that and potentially be inviting other executive members, particularly if they are not, if the areas being discussed are not in Councillor Harrison's portfolio. So when we start thinking about things like homelessness or community safety, effectively they sit in Councillor Mercer's portfolio. There may be cross-cutting issues around things like leisure services or some approaches in other areas which contribute to wellbeing. So Helen Howell is responsible for a lot of leisure and cultural offers which can dramatically improve people's well-being. So it may well be that there are items that this panel wishes to consider that are of significant interest to other exec members. Just to bring your attention to point 6, so whilst this is a non-decision making panel, each executive advisory panel will be politically balanced to ensure other political groups have representation on that. And whilst non-decision making, it is important to recognise that the advice that comes from this panel could influence the decision of the executive portfolio lead or the executive as a group as well. So absolutely, declaration of interests are really important. Some of the issues that we may bring forward later in the year around policy or strategy development, where you do have interest either in voluntary sector organisations as trustees or yourself, Councillor Lowell, as a having a pecuniary interest in a care provider. It's important that we discuss those and are clear about how you are involved in any discussion at those points in time. The EAPs will normally be held virtually. That's what the terms of reference say, but I know Councillor Harrison and I have had a discussion outside of that and feel that there would be some benefit to some face-to-face meetings, and we would like to discuss that with the panel as well. We can invite guest speakers or expert witnesses to attend a meeting of the EAP on an ad hoc basis, but it's important to remember this isn't health scrutiny. So whilst we may invite colleagues from the health service to come and talk on particular items, we cannot require them to attend, but naturally I am talking to them about the role of the executive advisory panel, and our health colleagues understand the importance that this will play in advising our executive on policy developments or ways that we are working with the health sector as statutory organisations in the local geography. Then just moving on to some of the practical elements. Obviously, we've got colleagues from Democratic Services who will ensure that minutes and notes of each advisory panel will be prepared and publicly available. We will be streaming the meetings. However, I understand if we decide to meet face to face, we may need to make provision for members of the public to observe, because we may have difficulties in streaming, which is much easier to do when we're all in this virtual environment than when we meet face to face, because we have to have the required equipment to enable us to do that effectively. Each EAP will normally meet on a monthly basis, and however, the chair can request the cancellation or addition of a meeting, of which I probably need to request that we would be considering an additional meeting or bringing forward an additional meeting around one of the topics which I think will be of significant interest to you, which is around integrated care systems. Just as the final bit, to just reference some of those other executive advisory panels, and I will go through this in more detail in my presentation later, just where we think there's a little bit of crossover with other executive advisory panels, but they particularly, I would suggest, are around the education, skills and employment and service delivery, performance and customers, because arguably some of the topics that we bring could fall across those. So I'm happy to then just open it up for members to comment on the terms of reference. Back to you, Councillor Harrison.
Thank you, David. I can't see anybody at the minute, so I can't see if hands are up or people are waving at me.
Let me stop sharing. So
that would be great.
Sorry, I'm not great on Zoom, so there we go.
There we go. Right. Okay. Now I can see everybody. I don't see any hands up at the moment. We have Councillor Roberts.
He's muted.
Ken,
There we go.
thank God you're there. Looking at the list of the other executive advisory panels, I think we should embrace all of those. Everything that we do, if you take the climate change, everything that we do has to have some element of it in that. And I think sort of cascading issues up and taking issues back as well, they can challenge us right back. I think that's going to be quite an exciting part of the work that we're going to do on this one. It might be that we need to have a meeting to discuss just that. How do we interact with the other ones, and how do we cope with that workload? I also like the idea of getting together in a room and perhaps going out and seeing some stuff in action, if it's possible, David.
Yeah. Mm.
Yeah. Thanks, Councillor Roberts. I think your point about the different EAPs and the subject matters that they are covering, you're absolutely right. There's going to be crossover pretty much at every point. I think that where we have to coordinate is in which of those groups will take the lead on a particular thing that's up for discussion. And of course, when the feedback comes from that, where it affects those other areas, it'll be fed back into those other areas as well. And if we need to invite people, so if we need to invite executive members for other portfolios to our meetings, obviously we would do so. And I think that's where the balance comes in. It's actually deciding which group looks at which issues, and that will be something that I think it says in the terms of reference that where there's any sort of dispute or disagreement about which group should look at that, it's the council leader who will determine. He'll be the arbiter of which group looks at which item. But of course, you're absolutely right that there's going to be constant cut across, and we have to be very aware of that and make sure that we're getting the right people to our meetings in order to get the most out of each of those particular topic areas for discussion. I'll go back in a minute to the meetings, whether they should be virtual or live, as it were. once we've given a few other people a chance to speak, because I've got some opinions on that myself. Councillor McGee.
Thank you, Chair. A couple of things to me, and I'm glad we're going to discuss about whether we should be virtual and all or not. I always think it's easy for people to say no when you're virtual. Face-to-face is always harder, and I much prefer face-to-face meetings. But that's a personal opinion. David mentioned about being political balanced. I don't agree this is a political balance meeting, but what I do agree is we should be political on this. We should be working together for the sake of the people of Northamptonshire, and I will do my utmost to do that. I will try my hardest. And the other one, Chair, David mentioned it's not a health meeting or committee. Health is integral to everything that we do, and I'm sure you know that. And if we don't have that opportunity to look at public health, and then we would be failing in what we are portrayed to do. Public health is a big issue across, and I'm glad he mentioned the integrated care system, because that affects public health, CCGs, and everyone in North Northamptonshire. So I'm glad that's on the agenda, Chair. One more issue, if I may. The cross-cutting issues also affects the other scrutiny panels, and I know the honorary scrutiny, if we can call it that, the other scrutiny panel, I mentioned the ICS, so I don't want duplication if we can help it, because that makes everybody's doing the same thing. We don't really want that, so we need to keep an eye on what the other scrutiny panels are doing too. Okay, thank you, Chair.
Yeah, I absolutely agree with you. Thank you for your comments on the political side of this. Absolutely, this is not supposed to be a forum for us to all be getting political. We just want to deliver the best for our communities, and that's why all of us are here. I don't think we'll have any problems with that at all. So thank you for that. In terms of the issue, I think David's going to come back in a second about the commenting on health issues. Of course, public health is within our remit. That is actually that's a local government responsibility. And, I mean, basically, you've hit the nail on the head on two of the really big things I think we should, and I'm sure you're going to agree, we should be looking at. One is the biggest public health issue that we have had in our lifetimes, which is COVID, and learning lessons from that, good and bad. Another thing is quite clearly the integrated care systems, and I take your points about not duplicating other people's work. I'm just going to pass over to David Watts, because I think he's got more to say on the issue of how perhaps we are looking at things that are health related in a way that is going to be useful for us as a council, but also in helping, particularly an integrated care system, getting it off the ground. So I'll pass over to David.
Absolutely, Councillor Harrison. That was one of the points which I wanted to make. I think it's just a point of clarity around the point I made around health scrutiny. So health scrutiny is a statutory function of the local authority, and what I was trying to make clear was that function sits with our scrutiny commission. So they have the right to call in colleagues from across the health system to account for activity that is being undertaken there, whereas we can invite as an advisory panel.
Understood. Councillor McGee, did you want to come back on that? You're okay. Councillor Roberts.
You've talked about COVID. I think one of the most important things is that what we did in Northamptonshire, what we did in North Northamptonshire, was viewed by central government as something very special, and others could learn from it. And I think the scrutiny point that John makes is really very good. We can inform, though, as well as get involved in some of the issues that sometimes arise in scrutiny. But one of the things I see us doing is, and I know I've mentioned it twice and you probably get bored with it, but I'm sure you won't, is that coming out of COVID, there's a lot of sick people who've been made sick by lockdown, and we need to be prepared for that big time. I'm seeing some in Barton Seagrove, I'm seeing some horrendous issues that have come out of this. and I think they'd look to our little committee to come up with some ideas and some support.
Okay, thank you, Councillor Roberts. I think all of those points are really incredibly valid and useful, and I think they're going to feed into the next the conversations we're going to have throughout this meeting, which is setting our agenda for the future. So I know that those will have been noted and will be considered, as a group we'll consider all of those things. At the moment I don't see any other hands up, so if you'll give me the leeway to bring up again the issue of how we hold these meetings. I've been assured that the sort of generic terms of reference that cover all the EAPs, executive advisory panels, were deliberately generic and very deliberately, I suppose, fairly straightforward. But in order that each group could change them if they wanted. These are our groups, these are our panels. And we should be running them the way that is best for this group. Now, my view is that meetings where you're going to get a lot out of, if we're going to have good, robust debates and actually get to the bottom of things and come up with advice and ideas. It's much easier to do that when you're in a room together. You can read each other's body language. The conversation can be much more free flowing. I find virtual meetings quite stilted, quite difficult. So I feel that we'll probably get more out of these meetings if they are done in person. But obviously I'd like to get the views of everybody on the panel on that, because as David mentioned, it will add extra issues. So for example, if we can't live stream those meetings, we have to make sure that the public can attend. So we'll have to get, at this point in time, a room that can be COVID secure with proper social distancing. But my strong feeling is that we will all, as a group, get much more out of these meetings if we do hold them in person. So I know that both Councillor McGee and Councillor Roberts have also expressed that. Councillor Lawal.
Hi, right. Yeah, I completely concur, Chair. I think it's an in-person meetings are far more robust, and you're able to get more out of it and get down to the bottom of things and really have a kind of a productive and anything. I'll just kind of highlight the issues in the terms of reference that could come from in-person meetings. I'm completely in favour of it, but getting guest speakers in may be something that we need to consider if they are in another county, another part of the UK. It may just be more of a challenge. I'm absolutely for in-person meetings.
I think that's a valid point about it might make it more difficult for guests to attend. I think what we could do is if we agreed that the default would be to hold our meetings in person, but where it became practical to do an online meeting because of those very issues that you raise, so long as everybody is happy that some of those meetings might end up being virtual, then that would be a reasonable position for us to take. Councillor Harrington.
Yeah, I just really want to echo that, because we've spent sort of 18 months almost now of Zoom meetings, and I think we're all fed up with them. But not just that, I do feel that we're far more open and feel able to speak when we're at normal meetings. So I am a great lover of being at a meeting where I can look at people and see their reactions, and that means an awful lot to me. So virtual meetings occasionally may be necessary, but where just the odd time we can okay with that. But I think proper meetings in person, I think we'd all agree with that they're what we're really looking to get back to. Okay, so that's it really for me.
Thanks, Councillor Harrington. Councillor Smith-Haynes.
Chair, I'd like to, whilst agreeing with everything that people have said, I'd like to flip that slightly in as much as we've just had our Freedom Day delayed. And so therefore I would be disinclined to arrange to meet face to face, for example, next month, for us then at the 11th hour to have to revert back to Zoom because Freedom Day is delayed yet again. I would be more inclined to say, well, let's say the first 2 or 3 meetings are via Zoom. At least then we can plan appropriately, especially as this is a new council and there's lots of other things going on. But with the aim to go face to face in time for Christmas, hopefully.
Thanks so much. Obviously, even if Freedom Day, as we are calling it, is delayed for beyond July, we still can have face-to-face meetings. We're having face-to-face meetings now. It just means that we have to make sure the room allows social distancing. So to be honest, I don't particularly see that as a problem. It's really overall what this group wants to do. We are perfectly legally allowed to have these meetings in person, even now. So I'm going to just go to David Watts, who's got his hand up, because he may have a view on this as well.
So, I mean, certainly from my perspective, what we don't want to do is stop people from being able to attend. So a lot of our health colleagues are headquartered in Northampton and will be very similar to me in that they tend to be in and out of back-to-back meetings all day long. So what I will, for any face-to-face meeting that we have, I will try and get my PA to see that we can source the right equipment to enable someone to dial in, which is different to the streaming issue. So that enables them potentially to be on a screen and we can talk to them. It doesn't deal with the streaming issue, but it does mean that potentially people can still be in attendance virtually as invitees, which would then hopefully limit the challenge that we might have around them actually being able to attend in person. So I'm happy to ask Helen to, sorry, my PA is also called Helen, to ask her to look at making those arrangements.
Yeah, I think that works. Councillor McGee.
Thank you, Chair. I don't wish to seem controversial on this, but if we're going to put this into terms of reference, maybe I'm cynical in my old age and I've been here too long, but if we don't have a strong wording about it being a last resort to have online meetings and when absolutely necessary, some people may just say, you know, oh, I don't want to travel there or I'm too busy. Yeah, maybe I'm being cynical and unfair. But I would like some strong wordings in there about how we say we would much prefer a face-to-face. Because as I said, Chair, in my experience through the years, it's easier for people to disagree or say no when on an online meeting. When you're face-to-face, you can read that body language, you can tell how people feel. So it's much my preference would much be to have a face-to-face meeting. Thank you.
Thanks, Councillor McGee. I think that David's suggestion that where people can't attend the physical meeting, that we would have the technology to allow them to dial into that meeting will solve that problem. And I think what that puts us on is now gives us the ability to say that that we want to hold these meetings in person. As you say, only in extreme circumstances would we revert back to virtual meetings, because the technology is there for people to, as David says, to attend via video link, and that ought to be sufficient. I really think that we need to, personally, I think that we need to get back to physical meetings. I know I take it, I absolutely accept all of the sort of convenience arguments that, when you've got back-to-back meetings and you're traveling from one place to the next, you're wasting time, and you could be, and I get all of that, but we're losing so much in not being able to meet and all those little conversations that people have behind the scenes, the general stuff. I mean, we've lost all that, and we're not just suffering professionally from it, we're suffering personally from it, and I really think that we need to get back to being able to see each other. Lucy, by the way, welcome to Lucy Whiteman, our Director of Public Health, who has sneaked into the meeting without me noticing. Sorry, Lucy.
Hello and welcome.
For
being late as well. But it actually kind of probably reinforces the point that David has just made. And without wanting to sound like I'm making an excuse as an officer, it is quite challenging to get from meeting to meeting, and I had to this morning, sadly it overlapped, so apologies for that. Just a really practical note though, the other reason I'm working from home, which is very unusual for me, is the fact that I'm having to self-isolate for the first time since the pandemic began. I don't quite know how I've managed to get away with it until now. My daughter's tested positive, and so the whole household's having to isolate. So there is that really practical element to the fact that absolutely advocate for all the reasons that Councillor McGee has said and others, that face-to-face meetings are usually much more productive. There is an element of the fact that we're going to see probably actually more and more as we come out of that last step of lockdown, people having to isolate. So I think we're going to have to find that combination of both, as David suggests.
I think that we have broad agreement here that we would like to be able to meet in person. We'd like to be able to utilise technology to allow people to take part in those meetings virtually if they can't attend, and that where it's absolutely not possible for it to be an in-person meeting, we will revert back to virtual. So if everybody just wants to do a show of hands to say that they're happy with that, brilliant, thank you. Lovely. Well, I think unless anybody else has any comments on the terms of reference, we can move on to the next item of our agenda, which is for David to give us and Lucy to give us a verbal update on the overview of the service areas that are encompassed by our executive advisory panel. So I will hand over, I guess, to David first.
There's two ways we can do this. So I'm just very conscious that the other parts of my portfolio are fairly expansive. So I'd like to offer Lucy the opportunity to go first if she prefers, just so that, and it's a hugely important agenda, not least because as earlier on, Councillor Harrison, you mentioned that we've had probably one of the biggest public health emergencies in modern day times, but equally Lucy, you know, really wants to set out how that has impacted on being able to deliver some of the other hugely important public health initiatives that we have over that period of time as well. So Lucy, are you happy to go first?
Yeah, of course. Thank you. And nice to meet those of you that I haven't met before. I'm hoping that some of you probably know a little bit about public health now, even if you didn't 18 months ago. But the Director of Public Health is a statutory chief officer of the council. You have to have one. Obviously in Northamptonshire, we've made the decision to have a joint Director of Public Health across the two unitaries, and that's not unusual. You see that quite a lot, particularly in London, covering different boroughs. So one of the things that obviously we have to do is basically be your principal advisor on all health matters to all of the elected members. I have a team and we both commission and provide. So we have a small provider arm as well as commissioning services, some of which are statutory, some of which are discretionary, from a range of different providers, from the VCSE sector through to very highly specialist NHS services. So from a point of view of our three key areas of work, people will be very familiar now with the fact that public health has a responsibility to execute health protection services. So I am statutorily required to ensure that I do all I can, and the council does all it can, to protect the health of the population that we serve. At this point in time, clearly there's a focus on infectious diseases. COVID is not the only notifiable disease I deal with. There is a significant list which you can find on the government website, but obviously we've had a significant focus on COVID for the last 18 months. But we deal with Public Health England in partnership. They have a different level of responsibility around health protection. But I am the person who's sort of responsible locally for the execution of services to do everything that it can to mitigate risk. The other two pillars of public health are health improvement. Again, people might be quite familiar with this. It's things like our smoking cessation services, our weight management services. We have low-level mental wellbeing support. We also provide directly a service called Supporting Independence, which is for people who've got mild to moderate frailty. And that, for example, helps people recover from slips, trips and falls. It helps people recognise how they can keep themselves well hydrated and have good nutrition in sort of frail conditions, and it very much is focused on trying to support people to live as independently as possible and not need to progress or put off that progression into adult social care services. So we have a range of services that we provide directly through our health improvement pillar. And the final one is the one that people are probably least familiar with, which is healthcare public health. So in the Health and Social Care Act of 2012, we have a statutory responsibility to provide public health advice and information to our NHS colleagues. I actually have a formal secondment for a third of my time into the local CCG, but other people just have a memorandum of understanding, etc. But I have a formal directorship in the CCG as well. But that can take all sorts of forms. So one of my doctors heads up the Child Death Overview Panel. We contribute to things called individual funding requests, which is for when people want services or treatments that sit outside of current policy or NICE guidelines. We have to undertake an analysis of what the risk benefit is versus the cost. We do things like joint strategic needs assessment, which people will be familiar with and sits under the jurisdiction of the Health and Wellbeing Board. So we have a significant business intelligence function that contributes to both planning for local services in the council, but also health services. And it looks at current need and service provision, and it forecasts need into the future so that we can better plan the allocation of our resources. There are a number of services we're statutorily required to commission or deliver. The couple that you'll probably be most familiar with are things like public health nursing services for 0 to 19-year-olds. So that's things like health visiting and school nursing. That sits with us. We commission our Community Healthcare Foundation Trust to provide that. We also have to provide drug and alcohol misuse services, so for current treatment, for reduction of addiction, but also for recovery programs. And again, our service locally is very focused on VCSE sector and sort of learned experience support and delivery. So we have a lot of VCSE sector organisations run by ex-addicts who provide peer support to people who are going through a rehabilitation process and recovery process themselves. We also have to provide sexual health services. Now, some of that's done in conjunction with NHS England because there are highly specialist services that they have responsibility for, which will be changing in the next 2 years with some of the integrated care changes. But for example, we provide services around sexual health screening, treatment for sexually transmitted diseases. We do the contact tracing for sexual health as well, which is obviously very similar to the contact tracing we now know around COVID, but making sure that people recognise if they've been exposed to a potentially sexually transmitted disease. We have responsibility for commissioning something called PrEP, which is post-exposure prophylaxis for HIV. So quite a broad church. We have responsibility for commissioning NHS health checks. So when you're over 40, your GP should be inviting you at least once every 3 to 5 years for an NHS health checks, which looks at your cardiovascular risk. So that's sort of a tip of the iceberg of the things that we're required to commission, but we also do have a lot of discretionary services that look at things like addressing inequalities through community development. We have a social prescribing programme which is about to be launched, which has been jointly funded by the CCG, and we've drawn in a lot of lottery funding, over £2.5 million worth of lottery funding with that programme of work. So huge amounts of work going on about basically giving people the best start in life, reducing inequalities and making sure that they have all of the right opportunities to have the best health and wellbeing outcomes locally. From a point of view of the team, as I said, we've got two broad teams. One is very much focused on the advice and the commissioning, and then the other is a small provider arm which provides all of those services I've just touched on, from the supporting independence through to smoking cessation and also workplace health. Our budget, about 3/4 of it goes onto those statutory services and around 1/4 of it is discretionary. But we obviously make sure it's focused on what the public health outcomes framework tells us are the current local priorities. And for North Hants, interestingly, the bits that we're not doing as well as we would want to do on, still very much focused around the kind of traditional public health services. So particularly childhood excess weight, chlamydia detection, so we touched on sexual health there already. Prevalence of smoking, Corby is a particularly challenging area around smoking prevalence, and we've had a lot of success with our current smoking cessation service, and we've just changed our offer to include things like vaping, so we're looking at harm reduction as opposed to complete smoking cessation. Some other cervical screening responsibilities, we need to have better uptake of women's smear tests. Smoking for mothers at time of delivery, again, still an area that we need to work on. And then we have quite a lot of, and I expect more post-COVID, of low-level mental health issues. So some of the things that we're doing at the moment is looking at where we've got any potential underspend in our current budget, or how we might want to use some of our reserve to start to address some of these really, intractable and long-term challenges. I know that's a bit of a whistle-stop tour and there's a lot more to public health, but in the interest of time, I'll probably stop there. I'm happy to take questions, or obviously Councillor Harrison return to this in more detail perhaps one time.
Thanks so much, Lucy. It is indeed a whistle-stop tour, and it's just amazing the amount of stuff that you do with such a small team. Does anybody have any burning questions for Lucy at this point, or is it something that we will return to later? Yes, Russell Wallace.
Sorry, I do apologise. Just to keep it simple, you mentioned hydration and muscle tone in older people, Lucy. By the way, I'm a fan. What we've done with COVID has been nothing short of a miracle. If we could find a way of sort of showing how important that is, it's a simple thing that we can do in the community, and yet it can save so much heartache and money at the other end of the spectrum, and it's making sure people understand some of these things are having a beneficial effect on the budget as well as on the people. I don't know whether that's appropriate in this meeting to say that sort of thing, but it's only by saying to somebody, look at the benefits, that's why we're doing it. And the other thing is that flu seems as though in the young seems to be something that's going to chase us a bit this winter. I wondered if you could comment on that.
Yeah, are you happy for me to come back, Chair?
Absolutely, go for it.
So I'm quite happy to go into more detail about some of our full services in the Supporting Independence programme. As you say, I think it's very much one of the services that this group would be interested in understanding a bit more about, because it's something that's quite unusual for public health to invest in. It's around about £1 million a year. And, quite often older people or frail people, because frail isn't always to do with age, but they are just considered to be the remit of adult social care and or the hospital, and people don't recognise that there are 3 levels of prevention. Primary and secondary prevention are about getting the right housing, making sure that people don't start smoking in the first place, and or secondary prevention, if they are smoking, helping them to give up and or lose weight, things like that. So the tertiary prevention bit, the bit where somebody already has a condition, there is still so much that we can do and that public health has a responsibility around, because you can improve people's quality of life, you can delay that need for more intrusive and, let's face it, more expensive services as well around formal adult social care. So that programme was very much looking at what the sort of gaps were from a point of view of provision locally. And the Supporting Independence programme dovetails very much with the Falls service. And we commission N Sport, so Northamptonshire Sport, and they do Otago classes, which are about strength and balance. But the Supporting Independence Wellbeing advisors, they do that sort of wraparound piece around, we get the fire service to come and do home safety checks to make sure that there's a reduction in trip and fall, risks and hazards. So they look at making sure people don't have rugs that have got edges that come up and things like that. So making sure their environment's safe, but then also touching on the other things that we talked about nutrition, about hydration, about making sure that people obviously know how and when to access support. They also have a kind of a befriending service, so they'll put them in touch. It's very much sort of social prescribing approach with other voluntary sectors, organisations locally, and or other people who work or live locally who may be able to provide them with informal support, because not everybody nowadays has family close to them. So there's an element of social prescribing and just sort of connectivity within the community that the Supporting Independence programme does too. So I'm more than happy to bring them along to one of these sessions to give you more detail. But flu, I'll be honest with you, and we might again want to do a deep dive into this later, we are expecting a horrendous flu season, because obviously last year with social distancing, there was virtually no flu. Obviously, if you socially distance, if you take infection prevention and control measures, you see a reduction in all airborne transmitted infectious diseases. So flu, literally disappeared almost last year. Our challenge, therefore, is what we usually do is epidemiologically we'll assess what strains of flu are around, and each year we update the vaccine. So there's what are called trivalent, so 3 strains of a flu in a vaccine, or there's quadrivalent vaccines, which have got 4 strains. And they put those different strains together, obviously looking at what's circulating across the globe, because there's usually a pattern as it goes around the world. And we look at what Australia is suffering with in our summer, and we, again, plan that into our vaccines. Because there was no flu last year, we have no idea which strains will be dominant this year. So although we will vaccinate people, it will be as a best guess of what strains might be circulating at the time. And again, if social distancing is gone, not only will we see COVID probably emerge and perhaps a different variant again, but we'll also slightly be gambling about whether we've got it right with our flu vaccination programme as well. And if people are co-infected, their outcomes are likely to be up to 4 times worse. You're 4 times more likely, for example, to die if you are jointly infected with COVID and with flu. So it's not a pretty picture, and we obviously are already planning locally and nationally as to how we might be able to, one, make sure everybody is vaccinated with the most effective vaccine, but also obviously looking at any other mitigating factors that we might need to, and indeed who we might be vaccinating with flu this year. We might see another extended campaign.
Thank you for that.
Thanks, Lucy. I mean, I think Councillor Roberts has brought up 2 very, very interesting areas that we could look at. I wonder if we are going to look at flu and preparation and what that might look like. It might be something that we have to look at earlier in our programme, because winter is when it's going to hit, probably in the autumn. So those are really interesting. And I was always also interested, Lucy, in the things you were saying about the supporting independent services, and it goes back again to what earlier on Councillor Roberts was saying about how an awful lot of what we're going to do will be cross-cutting other areas, because I immediately, as soon as we start talking about this, I'm immediately thinking about, well, at the moment we have very low levels of bus services, and if we want people to be independent and getting out, and of course not only is that going to help them from a mobility and a strength point of view, but it's going to help them in terms of their mental health and social isolation and so many other things. And we also need to be looking at safe places to be mobilising and exercising. Look at our wonderful country parks. We need to increase access to those. And there's just so many different things that could fall under just that one topic, and we could have such interesting discussions, and those discussions would be very, very helpful for us as an executive to be fed in and help us to say, well, actually, we hadn't thought about that, but perhaps that needs to become a priority because of its effect on that, which will affect that. And then, let's then get really down to brass tacks. As well as helping people, it helps us financially, because prevention is so important. So there's some really fantastic ideas there for us to look at. And where I've got a couple more hands up, and I mustn't hog this as I'm chairman, I'm not supposed to be going on too much. Ken Harrington, Councillor Harrington.
I'm okay with Ken, by the way, as well. I just wanted to ask Lucy, really, we can advise, encourage. How do we can't make anybody do anything at all if they don't want to, but how can we encourage a lot of people to be more aware of activity and connected with health? If I can explain myself a little bit better there, I am a little bit of a health freak. I believe in keeping fit, and healthy body, healthy mind. And is there more that we can do to encourage those out there to get more active, whether they be, because there's an awful lot of young people, obesity with young people, middle age and the elderly, but mainly the young. It worries me that we've so many young people who are actually obese. How can we encourage them to stop eating so many burgers and actually get physically fit again? Because that's going to save such a lot of money in the long run as well. We spend so much money on illnesses which is, I believe, very much self-inflicted. So what can we do to actually, we can't make people do anything at all, but what can we do to advise them to get fit again?
Thanks, Ken. And I think these are exactly the sort of topics of discussion that we're going to be having. I think today's meeting is really to set our agenda, and if we start discussing items now, we're not going to get anywhere. But you're absolutely right. I think these are all the kinds of things that this group is here to go into and to bring forward a package of advice that helps us to make the best possible decisions for our populations, our residents. So I think, you know, we're really beginning to, in this discussion, already sort of identify things that we might want to take to proper discussions in our meetings and go into them in great depth and look at them in the round and come up with advice. Councillor McGee.
Thank you, Chair. I love coming to a meeting when Lucy's here. You can hear and see the passion when she talks about the area she's involved in, and that's always fantastic to do that. You mentioned social prescribing. I think that is vital for us moving forward, and I hope at some stage we can have a look at that. And that's a big thing, social prescribing, anything from a local club to helping people to what they can get at the surgery, etc. It develops such a lot. And it's about a culture change. As for somebody that just had square sausages for me as a sportsman, not good for me, but I'll make sure I have my hour's walk this afternoon to try and to do something about that. But social prescribing is vital. It means many things. You know, during COVID, I was out helping one of our organisations deliver food to older people. And seeing the day I could tell them, yes, you can go back next week. They smile on their faces. You can see the weight coming off them. They're getting back out to that club that they enjoy so much. So that's so important that we have these small things too while we're looking at the strategic stuff. Thank you, Chair.
Brilliant. Thank you, Councillor McGee. So I'm just going to go to David Watts now. Thank
you, Chair. So it's probably just to really say, probably our first few sessions will be a lot of telling and showing. To give you an idea of what is going on and what the opportunities may be for this advisory panel to have a look at. I think the really exciting bit, and certainly I've talked to Helen about this, is how we can do more with the collective resources that we have as a council. And Lucy will talk about things like health in all policies and making sure that we are thinking around that. We've got so many assets as a unitary authority in North Northamptonshire that we could be thinking about how we use them differently to step out from maybe some of those normal advisory places, but saying, how can our other services really drive some of those messages where people are making contact with them? How do we use our libraries differently? You know, what is our leisure strategy in the north, and how do we make sure that that isn't just focused on perhaps getting people into gyms, but how we use some of our other resources to make exercise and activity more accessible to people, particularly in those communities where we see a wider health gap as well. So I think there's going to be some absolutely fantastic opportunities. I think the bit for us is, as an executive advisory panel, is how do we keep ourselves focused on the really important things? We can't, you know, if we try and do everything, you can't boil the ocean, can you? So we've really got to prioritise where do we want to address our focus over the next year, recognising that we may not be able to do everything, despite the fact that we all want to do everything, because absolutely I would love to get everything working tomorrow so that you know, we're offering those health and wellbeing messages in the right place. We're creating opportunities for people who perhaps can't afford to access organised activity or sports in that sense, that they have other options available which are readily accessible across all parts of our rural and urban communities as well.
Absolutely. Thank you, David. I think that's probably going to be our biggest challenge, is actually narrowing down what we decide to look at. Because just from this conversation, looking at Lucy and what Lucy does and delivers, we've already come up with, I've written down 6 different items. So we're going to have to somehow develop a system for deciding you know, how we're going to prioritise those things.
Or meetings, Chair.
At meetings, indeed, yes, indeed. I'm just going over to King Lowell.
Yeah, I think all the things Lucy mentioned, they mentioned there, Lucy, absolutely fantastic. A couple of things that's been mentioned already. I think Councillor McGee mentioned about social prescribing and others as well. I'd want to take it a step further. Actually, green social prescribing. I've been doing some research lately on this. I think this is a topic in which we can also discuss how to get involved with nature-based, get people involved with nature-based activities like local walks. Bedford's got a fantastic example of this with their lifestyle hub and kind of the link there to the public health in that area. So sort of how do we get people involved with more green-based activities? A bit of cross-cutting there with Harriet's portfolio, again, as you mentioned before, but I think it's something we can discuss as well. Locally, we've got things like the Green Patch. Get people. I know you've been there, Helen, to have a look at it. Absolutely fantastic, isn't it? Get them involved with that nature-based activities. I just wanted to ask Lucy, as you mentioned, and if I may, again, I don't know if it's the right sort of forum for this, but if I may, you mentioned about getting people off smoking into sort of vaping instead. And I just namely just a kind of a curiosity, has there been sort of a risk analysis of the vaping consequences, like the long-term effects of vaping in contrast to smoking, which we know the effect of? I'm just out of a point of interest, if you could ask that. But I also wanted to kind of pinpoint some of the work that Hertfordshire, through their Healthy Hubs initiative, their local council initiative, has been doing, such as working with Age UK on things like the COGS Club initiative for dementia patients, adult social care, older people, and things like cognitive stimulation. Do we work with the likes of Age UK as well on some of these community hubs initiatives as well? Thank you.
Lucy.
So from a point of view of vaping, actually there's only about 10 local authorities that have taken a harm reduction approach. And that's because obviously some of the longitudinal research around the effects of vaping aren't fully understood. What we do know is that of the research we've got, which is around, well, it's between 10 and 12 years worth of research now, which in the grand scheme of things isn't, long term, but we know that it significantly reduces the risk of a negative respiratory outcome. And therefore, the Association of Directors of Public Health and the Faculty of Public Health have made statements to say they support vaping from a harm reduction perspective. Ideally, we always engage first in a conversation about quitting any kind of, nicotine products at all. But if people find that difficult and or aren't ready to take that step, we have got the evidence that obviously vaping considerably reduces the harm as compared to smoking tobacco. But you're right, there is still an element of we don't know what the long-term effects of that might be. What I think we can confidently say is those side effects of vaping are going to be significantly less harmful than continued smoking would be over that period of time. So that's why there's still quite a nervousness about some local authorities taking that approach. Because we've had some really stubbornly high smoking prevalence, that's why we've done this. And we've found that we've opened our smoking cessation service up to a much broader group of people, particularly younger people, who otherwise would have continued smoking tobacco. So yeah, we are aware of the fact that it is not a risk-free outcome, but it's certainly much less harmful than continuing to smoke tobacco.
Yeah.
David, do you want to take the cognitive behavioural piece? It's more aligned with some of your work, but we do work from a point of view of, we also have adult learning, I should have said, in public health as well. So that sits with us. It's ESFA grant funded, so there's conditions around it, and it's very much focused on getting those furthest from work back into gainful employment. A lot of the work that we do is about key skills, but we also do a lot around social, mental well-being, because actually a lot of people have significant anxieties about getting into work and or being able to continue to work, or indeed have become unemployed due to some low-level mental health issues. So we have what's called Learn to Be, which is a whole range of low-level cognitive behavioural therapy support, which helps people get back into that setting. We also have mental health first aiders that go out and provide workplace training, and we've also got mental health first aiders trained within the councils. So we've sort of addressed it both as an employer and also as a local provision, but we don't commission any significant clinical psychiatric support. That's not within our remit as such.
Thank you, Lucy.
So I think that we've had a really good discussion now around a large number of things that fall within Lucy's public health brief, and quite clearly we're already full of ideas about what we might want to look at. And I think it's going to take a little bit of thought about how to arrange all of that and how to. I'm sort of throwing this out there without necessarily having thought it through, because I'm just listening to what you're saying. But I wonder if there's some sense in looking at some of this public health, some of these public health issues in the round, because we've talked about health in all policies. We've talked about prevention. We've talked about social prescribing, and I'm just wondering if we can bring all of that together so that we can be looking at all of these issues, perhaps not going deeply into the detail of how we provide smoking cessation programs, because that's quite down to officer based and very much experience based and evidence led. It's very interesting for us to know how it's delivered, but it might be that we want to see how that all fits into a bigger picture of how we can use. I don't know. I'm not sure I'm making a huge amount of sense, but I'm just wondering how we can look at some of these things, but perhaps more in the overall picture, and how we as a council as a whole can start to ingrain and embed some of this prevention and social prescribing sort of strategies to help public health to make these things happen. I think that's what I'm trying to say. Lucy, you probably got a view on that.
It was going back slightly to what David said earlier. I think there might be in our next one-to-one, Councillor Harrison, perhaps we could have a think about the agenda and the kind of sequence, because there is a kind of a logical fashion to some of this, and we could start looking at those very strategic things around health in all policy, inequalities framework development, which is something that my team is just starting to do on behalf of the whole system, health and social care system. So there's something about having some of those strategic conversations, and that will answer some questions, but actually I think it might also help us then prioritise which other areas we want to do a bit of a deeper dive into. So if you and I could take that offline with David, I'm sure, just to have a look at how we can sequence some of that.
I think that would be really helpful, and then we could bring it back to the panel and hopefully get some agreement on how to go forward with that. So thank you for that, Lucy. I'm just going to whiz to Councillor Roberts, then hand over to David to take us through his area and any final comments on the section we've just talked through. So Councillor Roberts.
I thought you were making great sense, actually, and I'm glad that you and Lucy are going to sit down and think this through. I think it's all about outcomes. We have to have an understanding with the community, because we're going to give them some hard choices. We're going to talk to them, you know, grown up talking. Do not keep doing this. It's harming you for these reasons. I think it's all about the outcomes. I think we want to make the community as a whole, North Northamptonshire, a great place to live, work, rest and play. And in so doing, they've got to come with us and they can help us. They can be part of this. So all of this will sort of hone down to better health and a better way of living in North Northamptonshire. And it's complex, but it can be honed down to a simple message.
Councillor Roberts, and then over to you, David.
Thank you, Chair. It was probably just to try and make a little bit of a helpful suggestion. Lucy, I don't know whether it might be helpful at a future session to do a little bit of an introduction to the Joint Strategic Needs Assessment as well, and how that sort of informs some of our approaches moving forward. So it's a suggestion. You may well have a better idea, but that's just it may be helpful for panel members to understand what the Joint Strategic Needs Assessment has told us previously and how that shapes some of our policy moving forward.
Thanks, David.
Can I just add to that just very quickly? So because I think we have a slightly different approach, perhaps even that you're used to, David. We don't do a single joint strategic needs assessment like some areas do. We've got a suite of different types of product that sit within a joint strategic needs assessment kind of remit. And we do basically a cycle of refreshes, and we also do deep dives dependent on what the council is commissioning at that point in time and or what their priority areas are. So it's a slightly different approach to what other local authorities may have taken, but I'm happy to talk through what we've done and what needs refreshing, because obviously we've had a period of 18 months where basically my team have not refreshed anything. So there is a backlog of work, and again, it would be useful to get your views on what we prioritise as we start to try and do that piece of catch-up work, actually.
Thanks, Lucy. Back to you, David.
Okay, thank you. Members, you will find in your email inboxes a copy of this presentation. I just find it's helpful to do a little bit of a takeaways that you can reflect on things afterwards, but didn't want to share it in advance because it's much easier to talk through. I'm not going to go through in massive detail. I'm going to touch on some of the pertinent areas, if that's okay with you. And I've also made a bit of an assumption in the fact that the majority of you will have quite a lot of experience of working in sovereign councils, so in district and borough areas, but may have a bit less experience with some of those county services, so particularly the adult services areas. And equally, that is such a significant part of our council budget and service delivery that I thought you may want me to focus on that initially, but also make reference to some of the other areas within the portfolio where I think there would be some useful discussions to take forward. So if you're happy for me to take that approach, I will run through, but recognising that I've gone heavy on adult services this time round, but recognising there would be more opportunity to discuss those other areas. If that's okay.
Sounds good.
So my screen's now gone. Oh, there we go. So okay, so to try and chunk things up a little bit, I've sort of set out the areas within adults, communities and wellbeing, and Lucy, I've taken a bit of a liberty in including your area in that, where I think this executive advisory panel will probably be interested. Some of the others are up for debate, but I think these are ones which really sit clearly in the lead of this executive advisory panel. I'm not going to go through them in any great detail. I'm just going to pick out the ones which don't say on the tin what they are for those of you that perhaps aren't familiar with the acronyms. So PBSS on the left-hand side is Personal Budget Support Service. So the way that some people receive their adult social care is not as a directly provided service. They're provided with a budget to then enable them to go off and buy services that suit their needs. The next one is CHC. So in the second column, we've got CHC, that stands for Continuing Healthcare. And that is effectively where people have care needs that are above and beyond the remit of the local authority. But clearly where there is a cut-off and where there is a dividing point, there can be a bit of a challenge in discussion between ourselves and health services around who is taking responsibility for the care and support needs of those individuals. The other area which probably doesn't say on the tin what it is adults brokerage, which refers to the way that we commission from the private sector. So I'm sure Councillor Llewellyn is probably fairly familiar with adults brokerage, but and Councillor Smith Harrison, but it's the way we have a particular team that makes contact with care providers, puts care and support packages out to the market for them providers to say whether they can potentially meet those needs and provide that support. It's quite significant in that sense, as in there are hundreds of changes, there are temporary packages of care. We often put small elements of support in to enable people to get out of hospital for short periods of time. So it undertakes all of that function in that sense. And then probably the other thing which needs explaining is the Shaw PFI. It should actually say Shaw PPP, but I can never find the original. This is a picture of the structure chart, and I've got one which has changed and I can never find the right one. But a number of years ago, in the early 2000s, Northamptonshire County Council outsourced a number of care services in the north of the county. So they were older people's residential care homes to an organisation called Shaw. That was part of a public-private partnership arrangement, and we host that contract. It's fairly significant, about £9 million per year that we spend on purchasing the support from those care providers. And we also had some Shaw PFI initiatives, which were private finance initiatives around outsourcing some of our reablement services to a number of building-based services which Shaw originally took on. The Shaw PFI came back in, the care elements came back into the local authority before vesting days, so came back into Northamptonshire County Council in December of last year, and is hosted by the West, but we still use a number of services within them because 3 of those buildings are based in the north of the county. But the key element for me, and probably for you as a group to understand, is our relationship with the PPP contracts, so the outsourced residential care homes, because there are concerns about the performance and the value for money that we get from those at this moment in time. And I think the rest of those are probably self-explanatory. Adult social care, there's a bit of a statement there. I'm not going to read through it. You've got it in the pack, but this was just taken from Community Care magazine 2008. It's just a very good sort of explanation of what we do. It is primarily around supporting people to remain independent, and quite often that can be a challenge for people that use our services and their relatives, because they think that by trying to keep people independent, we're not supporting or we're not meeting needs. So there's a fine balance between re-abling, enabling, and then supporting and providing care and getting that balance right and making sure that it's done at the right time. You'll also be aware that prior to transfer to the new unitary authority, that there was a significant amount of transformation underway in Northamptonshire County Council around adult social care. Generally speaking, these are the principles that sort of we are sort of aiming to try and achieve. Sort of links back to the statutory duties that we have, the core principles that were built into the target operating model for adult social care, and the aims and the ways that we will try and address those. So fundamentally, we will always try and prevent need, and be that through services that we provide or through working with other areas of the council, with our health colleagues, with public health to address some of those issues moving forward. Where people have needs, we will always try and reduce those needs, either by enabling them to become more independent or to regain a level of independence that they may have had before a medical crisis or injury or accident of some sort. You'll have to excuse the doorbell. That will keep ringing until my daughter goes and answers it. So it's a little bit of way for it to get to the front door. There's also issues around eligibility for adults. So that when we get involved, not everyone is entitled to adult social care support. There are sort of eligibility and national eligibility criteria, which was defined under the Care Act, which was brought into statute in 2014, and that brought together a number of previous acts that had been developed over the years, such as the NHS Community Care Act, the Chronically Sick and Disabled Persons Act, and parts of the National Assistance Act. So going back as far as 1948, and sort of Beveridge and all that area as well. And as you can see on the right hand side, those are the sorts of areas that we look at when we are determining whether people do have eligible care needs. We have a similar responsibility around carers as well, so ensuring that we adequately support carers of individuals who have care and support needs. Those are defined within the Care Act as well. And what I would say to you is, if we didn't focus on and support those carers in the right way, we would probably find that the council would be bankrupt, because there is so much care and support provided by informal carers that if they all suddenly stopped, we would not be able to, probably with the full extent of council resources, if we stopped every other service, we would probably be unable to meet the needs of everyone as a result of that. So it's really important, and we do focus on the well-being of carers within our geography. So just to give you a bit of an idea of the transformation that has been gone through, so it's referred to as the target operating model, or was referred to, which sort of started in July and September of 2019. And I have no doubt that you will say to me, David, we want to see some of the work that was done around that and understand that as an executive advisory panel. And I'm more than happy to do that. I've shared it with Councillor Harrison. It's quite a lot of information, but I haven't been through it in detail with her yet. But there was a significant diagnostic undertaken, which is then designed, one, the transformation, but also two, the savings delivery that we as a local authority have committed to around adult services, in order to try and ensure that we have a sustainable council moving forward, because it is 40% of our council's budget at the moment. So absolutely imperative that we understand that we are spending that money well, and supporting people to regain and become more independent wherever possible. One of the underlying principles of the model that's been implemented in adult services is called 3 Conversations. It is a nationally recognised framework that sort of structures the types of conversations that we have with people who may have care and support needs. Conversation 1 very much about making those first connections to people, and you take an approach around really looking at the strengths that they've got, the skills they've got, the resources they have around them, family support, how active their local community and neighbourhoods are in trying to find solutions to some of the challenges. So it might be that they're socially isolated and that's impacting negatively on them. They've become less mobile because they're not coming out of the house much. So how do you connect them back up to the community to get them more active, get them more mobile? And that may well solve their problems without having to have social care support. It may enable them to become more resilient and connected as well. Conversation 2 is probably the most important conversation that we have, in that it's the one that we are having when someone is in a point of crisis, be that a medical crisis, a mental health crisis, carer breakdown, or any other sort of challenges which they may have. And what we don't want to do is make assumptions at that stage, and we want people to feel really supported. So one of the core principles of conversation 2 is that the worker who is involved with them will stick to them like glue. They won't refer them on to other services. They will connect them and stay with them whilst that other service engages with them, and try and help to stabilise and then reduce down their care and support needs. There are clearly people who will always have care and support needs after you've been through those processes of conversations 1 and conversation 2, and people can move between these as well. So you can have someone who's had a stroke and their recovery is quite quick in the first month, but then it sort of plateaus. But then they recover over a longer period of time in a much more slow way. So we encourage the principles of both conversation 1 and conversation 2 to be used in conversation 3 as well. So always looking at, when we're talking to people about their long-term care and support needs, is, are there any more opportunities to support you to become more connected or more enabled moving forward? Next part really is about how we work with health, and one area that you may want to consider looking at is our approaches around discharge to assess. This is how, well, it's certainly a model that was really driven, particularly over the period of the pandemic, and sometimes with some negative impacts. So ensuring that people's long-term support needs aren't decided within hospital. We primarily try to discharge people, usually to their own home, and then we assess and support them in their own home and then design their reablement programs there. Whereas sort of previous models tended to mean that you were doing the assessment in hospital, people would wait there for quite long periods of time when they didn't need to be there, and quite often would lose function as a result of doing that. So we have effectively those 3 pathways explained there, and it will probably be helpful at some point to give you a bit of an idea about how well we think we are doing within those, which is a mixed bag, and we have to be honest. So happy to bring those forward as well. The numbers at the bottom of the elements around safeguarding are county-wide. We don't have the figures for Northamptonshire because it was not reported on those sort of geographic footprints, but it gives you an idea of the amount of safeguarding calls we had in the last year, how many of those actually became alerts, so we needed to find out more information, and then those that progressed on to being formal safeguarding inquiries. So quite a significant amount of activity. What it is important to recognise is safeguarding of vulnerable adults, our statutory functions relate to people who have or may appear to have care and support needs. So it doesn't apply to people who are members of the public without care and support needs, albeit we are mindful of and concerned about people who are on the periphery of eligibility. So they may not yet meet care and support needs, but abusive behaviours towards them may push them over and mean that they require support around substance misuse or mental health or as a result of physical injury. So we do get involved in people's cases where there is a risk that they would become eligible for adult services if we didn't. Mental capacity is another key area for us, and it's going to become more of an issue, I would say, from April 2022, because the processes around mental capacity, the Mental Capacity Act and the deprivation of liberty safeguards has been reviewed by the Law Commission, and new proposals are being brought forward, supposedly for implementation in April 2022. However, at this moment in time, that has been delayed on a number of occasions, and we still haven't got the code of practice, but it could have an impact on the way that we support and assess whether people have mental capacity issues, and if as a result of that there are risks around them being deprived unlawfully of their liberty by the care and support that's provided to them. So whilst generally speaking we would say, well, we think it's good that people are being supported and they've got care and support needs, you can be too restrictive in the way that you provide support to them. And the Mental Capacity Act and what will be the liberty protection safeguards are all designed to make sure that where we are supporting people, that we are not being too heavy-handed in that, and we are using least restrictive options to support people. That again becomes a problem, because quite often we have families saying, we think our relative needs to be in a care home, but that's probably for a large majority of people too restrictive an option for them. So we have to try and work with those families and advocates to explain why another form of support may be more appropriate in those circumstances. Two of the big areas which I will insist on bringing to this executive advisory panel. One is integrated care across Northamptonshire. So this is effectively our partnership and improvement programme around working across health and social care in the whole of Northamptonshire, so not just North Northamptonshire. It's how we work with our acute hospitals, how we work with primary care, how we work with community nursing services and mental health services. And it's partially driven by finances within the NHS and having to deliver efficiencies and savings, but it's also around recognising the right sorts of outcomes for individuals and how we should be supporting them. Connected to that is integrated care systems. So they are two separate things. One is about the operational doing. The second is really about the governance and structure that you have around that to commission and support the operational doing of integrated care. And I haven't updated this slide, but we had a health and care white paper earlier this year, which has effectively set out a very short timeline to implementing integrated care systems, and in particular an integrated care statutory body within our local system by, again, April 2022. It is a structural change, and we have opportunities to define how we work with that as a local authority. And we have a fairly tight timeline. So if you're going to have a statutory body in place by April of next year, we need to be really clear by sort of late summer what that's going to look like and how it's going to be implemented. And one thing that I am extremely clear that I would want to do is engage you in that discussion. There's been a lot of work by officers within the health service, within the CCGs, with the acute hospitals and the Partnership Trust, and ourselves in the local authority around exploring how we can set that up. But I'd like to bring the proposals to our next executive advisory panel, or potentially, because of the way that this links with our executive, look at bringing forward a executive advisory panel to sort of towards the end of this, towards the end of July, if we have, I'm not sure on the dates of them at the moment, but if the timing doesn't work, we may need to just potentially bring that forward, but that will enable then Councillor Harrison to be able to go into our exec having tested some of the assumptions, some of the design principles with yourselves as an executive advisory panel to then advise the executive on that. Another area that you will hear about is the Better Care Fund, and whilst we feel that integrated care systems will probably supersede that, at this moment in time, the Better Care Fund is the legal way that we can combine funds with the health service in order to achieve better outcomes for people. So by creating a Better Care Fund, pooling budgets together, we can incentivise closer working together. And there is still a requirement for our Health and Wellbeing Board to sign off our quarterly performance around that, and I think it would be helpful to at least do a show and tell bit around what sits in our Better Care Fund at the moment and why it sits there. However, we are in the process of refreshing that in light of the two local authorities being created, so I'd suggest that's later in the work plan. Another area of interest, and those of you that watch Panorama will be probably familiar with an appalling state of affairs in a private hospital called Winterbourne View, which was commissioned by health and local government on a person-by-person basis to provide support to people with complex learning disabilities and autism. After a Panorama investigation exposed the high levels of abuse in that care setting, the government brought forward transforming care partnerships as a way of saying we don't want our most vulnerable people to be out of sight and out of mind in these really specialist hospitals. We want to find ways of helping them to integrate into our local communities and to be supported in the neighbourhoods where their families live and where they've grown up. And that programme is ongoing. There's an additional 3-year plan which aims to reduce the number of NHS commissioned specialist beds and redirect those resources to supporting people in the community. So I think it would be helpful to share a little bit about our progress on that, but also some of the challenges that we're facing moving forward. I've mentioned ICANN, I won't go for it in any detail, but these sort of ICANN statements sort of help you understand what we're trying to achieve by that transformation. Similar to the target operating model, we've got a bit of a roadmap which sort of explains some of the milestones that we expect to see over that period of time. One area, so you'll see on the structure chart that I have an Assistant Director for Commissioning and Performance. So we spend a huge amount of money in the independent sector, buying care and support from independent domiciliary care agencies, supported accommodation providers, extra care, and also residential and nursing homes. And one of the things that I would like to bring to this panel is really about how we shape that market, and we test councillors' views on where we should be going with some of this. I have fairly strong views that I'd like to test and make sure that there's political agreement that those are the areas we should be investing in. So I think one of the things which I talked about at my interview when I joined the authority was underinvestment in extra care provision in the north of the county over probably a couple of decades really. So we sort of lag behind in that space, but that is a really viable and high quality alternative to residential and nursing care, which also enables people to remain more independent, but requires investment from a local authority to put that in place before you can decommission some of those other services. So that's something which I would like to bring is one of our assessments around the demand that we've potentially got for extra care, and then to think about, well, how do we influence the council's policy and invest in that area moving forward. We also obviously have roles around maintaining the quality of providers and managing provider failure as well. Just to give you an idea of the care home ratings that we have, so the majority of our care homes are rated as good, but there are a significant number that are currently requires improvement. It's important to recognise that Care Quality Commission ratings are at a point in time, so many of those providers will have improved, put in place the necessary improvement plans, but not being re-inspected by the Care Quality Commission. But it just gives you an idea of what we are keeping an eye on in the market. And we have a very small number that are rated inadequate, and we have a high level of involvement with them through our commissioning team where that actually happens. This is a really interesting slide. So we're trying to also understand the impact of the COVID pandemic on our care home usage. So you can see this is county-wide, not split by Northamptonshire at this moment in time, but the chart on the right-hand side just sort of sets out some of our very high levels of voids within those care homes. And as you can imagine, care homes are reliant on probably being fairly full, usually around a minimum of 90% to be financially viable, or they're losing money. So we've got a large number of providers that have just dipped under that sort of 90% occupancy level, so 49 providers there. But we've also got in excess of 50 providers county-wide that have less than 80%, and that leads to concerns with market stability, and making sure that we have a varied and available market for people to access, so that they can make some choices about where they live. So again, possibly bring in regular updates, be it, and by regular I'd be probably suggesting, because the CQC ratings don't change significantly, maybe a quarterly or half-yearly update on what activity we've been doing around some of our poor performing providers, and any changes within those over that period of time, more as a share for information, but also give you the opportunity to challenge us as a service around what more we could be doing in those areas, and perhaps for you to understand what some of the activity is that we do to support providers which are either inadequate or requiring improvement, and supporting those providers that are good and outstanding to maintain those ratings as well. I have dropped in a slide around savings, impacts of the full year impacts of decisions of the previous authorities that were made, just to give you an idea of the scale of savings that have been expected to be delivered as a result of it. So you can see that there. However, what's important to recognise is that if we continue as we are, the council has a significant financial gap as of next year, starting at 19-20 million, of which, when you're 40% of the council's budget, there's an expectation that we continue to look for opportunities to find efficiencies, but continue to maintain high quality services and supporting people adequately moving forward. Not least, this is a national challenge, and you'll all be aware of commitments around bringing forward proposals to set social care on a financial on a sustainable financial footing moving forward in social care reform, but we've yet to see those proposals coming forward. So we can't wait for that national steer on that. We have to come up with our own solutions locally, and then when those national proposals come forward, look at how we dovetail those into some of the activity. And just to give you an idea of headcount and the sorts of roles that we have under those assistant directors for adult services. So under Trace's area, headcount of around 70 people, 75 people. When fully staffed, and that consists of commissioners, so people who shape the market and carry out assessments to determine what our future needs will be around care and support services, brokers who are then directly engaging with the market to make sure that immediate care and support needs are support packages are commissioned for, and then our financial assessments team who do things like provide appointeeship. So where people don't have family members to support them, will act on their behalf to receive benefits and administer that on their basis, on the basis of maybe paying their rent for them or paying their housing. Receiving their housing benefit and other benefits and distributing that appropriately for them. The other element that the financial assessments team does is you may well be aware that adult social care is not free like the NHS, so people are financially assessed to what their contributions might be towards the cost of their care. Doesn't necessarily fit comfortably with social workers, but we have a specialist team that undertakes those assessments, but also try and make sure that people are also claiming the right benefits to maximise their income for themselves as well. Then under Sam's area, we have a head count of 360 people, which really is in relation to social workers, enablement and assessment workers, carers, support workers and progression workers who tend to work with our younger age adults around moving on, becoming more independent, maybe getting their own front door, getting into employment as well. And then we have a current vacancy for the Assistant Director of Safeguarding and Wellbeing, which we're interviewing for next week. And within that area sits our provider services. So we do directly provide some care services, but also our approved mental health service. So the specially qualified social workers who undertake Mental Health Act assessments and are authorised to lawfully detain people against their will or contribute to that where it's deemed that for their safety or the safety of the wider public that needs to happen. We also have a therapy service which consists primarily of occupational therapists, but we also have a relationship with sensory impairment which is hosted within West Northamptonshire. There are a number of services that we use which are provided on a host arrangement by West Northamptonshire, and some that we provide on a hosted basis to West Northamptonshire as well. And some of the discussions that we may want to have at this panel is around longer term, what we want to do with those services moving forward. So whilst at the point of setting up the unitary authority, there was a commitment to, well, we want to be our own unitary authority and we want to have our own services. There are still benefits in some circumstances to having services provided jointly on behalf of both local authorities, either because of the specialist nature or the small size of that service. So we would like to bring those forward. And then I guess the final bit is really what I would say is the high areas of focus. Clearly, we would want to bring any strategy development. So the sorts of strategies which you would tend to find in a local authority would be something like an autism strategy, assistive technology strategy, market position statements and commissioning strategies, and clearly in the other areas of my portfolio, housing and homelessness strategies, we want to be bringing those for early discussion to inform the exec decisions around whether they're fit for purpose and what we need to be doing in that space. And I've just dropped in there the areas where I think there's probably crossover significantly with other portfolios. So, and it may not appear straightforward as to why for some of those, but so take adult learning. Adult learning can really make a difference to people's well-being, particularly in later life where perhaps they've become unemployed and are struggling to get back into employment. So you may consider that, whilst that probably fits under the remit of the education skills EAP, that there may be elements that you would like to see here and would want to negotiate with the chair of that EAP that they come forward in that sense. Now, I know I've taken a huge amount of time there, but hopefully that gives you a whistle stop of where what sits within that adult services portfolio.
Thanks so much, David. Indeed, it covers an awful lot of stuff, but that's because there's a huge amount in there. And I think that was a really helpful overview for all of us. It's great for me because each time we go through these things, it sort of starts to get more and more into my head exactly what we're dealing with and what we're facing. And you came up with some really strong areas of things that we could look at. And I think some of those are going to be absolutely vital. We've got about 8 minutes left of this meeting, and I'll quickly go around the room if that's okay. And I think what would be a really good idea now is if David, Lucy, and I get together to develop a suggested programme, which we then bring to the next meeting, which is on the 23rd of July. Now, I say that bearing in mind David's comments about the integrated care system work that might, I think, David, you were saying we might want to look at before the exec on the 5th of August. I think that was the executive meeting you're referring to.
Yes.
Fine.
Well, there's actually two. So the integrated care programme has an ambition that all boards will have signed off the proposed approach by the end of July. Right. I think that our 5th of August exec is probably the place. I think it's close enough to fit with that. Yeah. But clearly we would want, in order for papers to go live for the exec, we have to have our EAP early enough to enable anything to be, any amends to be made or any advice to go forward to exec, if that makes sense.
Yeah, so I think if the panel is in agreement that we need that bringing forward to us prior to the 5th of August executive, I'm not sure now, I'm just trying to think, would that fit with the 23rd of July EAP meeting? If so, we could bring it to that. If not, we can.
I think if we go to the terms of reference, I think for anything to be considered by the exec advisory panel, the advice is that you then as chair will take that into exec. So I think reasonably we could use that. My only concern being if we came up with some absolute deal breakers, and that, but I doubt there will be, having seen the work. I think what you will be reassured by is the role of the local authority in that and how it will be engaged, and that's probably going to be one of the key areas which you are wanting to be assured about and to be able to pick at and challenge a little bit. So I think if the panel's happy, I would suggest we go for the 23rd of July, and I will seek to make sure that some of our health colleagues, so I would suggest that we try and invite Toby Sanders from the CCG as the chief exec there to come and maybe co-present with myself and Lucy around what we've been doing in that space.
Yeah, I think that makes a lot of sense. So it could be that at that meeting we have that as the sort of main agenda item, plus looking at the proposed work programme going forward for us to look at and agree on or disagree on at that meeting, if that works for everybody else. Councillor McGee, you have your hand up.
Thank you, Chair. I know there's not much time, so I'll try and be quick. As for the ICF, it's a very short time, and it's not the officer's fault, it's not our fault as councillors, but it's a short time to have a say in there. And you know, I've got questions about the whole issue of that, you know, the governance of it, how you know, the impact on the CCG, public health, our council. It's a lot of questions we're not going to get an opportunity to ask, but it will go in front of other areas. But I think that's a great shame. There's always a rush for these things from central government. We don't get the opportunity to steer that in the way we would like. But you know, we'll look at it. But Chair, can I just throw some other things in the pot for you to consider looking at as we move forward? We touched on leisure there. I know there's a policy coming forward because we all do leisure in this North Northamptonshire in a different way. There's a policy coming forward soon. We should be having a look at that policy to be able to make some suggestions of how that, because leisure is vital to the health and well-being of our communities. So hopefully we can do that. Another issue we have is facility adaptations for people's homes. We know the backlog COVID has caught on that, and we need to catch up on that. And part of that problem is occupational therapists and how we can try and influence that and make a difference to get people staying home longer. The other quick one, Chair, I did have a question about the 44 vacancies. That's quite alarming, isn't it? 44 vacancies under a safeguarding and wellbeing department. You know, we should look at that and the impact of that for our residents as soon as possible and try and get things in place, recommendations to try and improve that. I'll leave it at that, Chair, because we don't have a lot of time. We'll have another opportunity at the next meeting.
Yeah, thanks, Councillor McGee. We'll take all of those suggestions and try to build them into our programme. I'll come to David in a sec. I'm sure he will comment on the unfilled posts within safeguarding. If I can quickly go to Councillor Llewellyn.
Right, I'm aware we've got two minutes, but I'll try and get through some of these questions and points. So you mentioned, David, about some fantastic points about enabling care, enabling service users to gain independence. But as you know, there's a shift towards changing the culture of in control of, rather than in partnership with service users in care planning. I just wondered what we're currently doing about moving towards the co-production, co-design of care planning for individuals and service users, enabling sort of full confidence to participate in their care planning as and when, and if needed, assistive technology and training and support networks to kind of get involved with that whole co-production piece. That's the first sort of point of question, if you can address that. And secondly, are we doing anything about the use of technology in adult social care, namely to kind of reduce the excess provision, and also sort of considering new tech ideas like sensors or biometric readings and analysis to monitor declivity or deterioration, kind of stopping and preventing hospitalisation where we can? If you can just kind of address those 2 points, or if not now, to the time at the next meeting.
Thanks, Councillor Llewellyn. Those again really important points, and I'm going to come back to David Watts in a moment to talk about the co-planning of care and assistive technologies. Quickly going to go to Councillor Smith-Haynes first.
Yes, thank you. Being brief as well, thank you very much for that whistle-stop tour, David. I was wondering whether you could produce a white paper for dummies for us councillors, and particularly those that haven't actually worked within the system, or is there a practitioner's guide that's available that we could have eyes on that would just help to fill out the information that you've given us today?
Thanks, Chrissy. Councillor Roberts.
Very quickly, one point. Enabling our staff. I know the numbers, John quite rightly says that the numbers of vacancies is something we should look at, but we also need to enable them to make decisions at the front line, because when they make decisions at the front line, they can spend a little bit of money and save an awful lot. So there's a two-way street on some of this. I had other things to say, but I'm sure there'll be another meeting somewhere down the line.
I think the fact that we're running out of time tells us everything we need to know about this group. And thank you so much for all those questions. I'm going to quickly let David cover some of those points, probably fairly briefly, but obviously we are going to come back to all of this. We are going to come back with a programme for your agreement. And what we need to do is try to make it as streamlined and effective as possible, so that we are being as effective as possible. So let me just quickly go to David
Okay, so just very quickly, on the 44 vacancies, they're not in our safeguarding services. What sits under that portfolio is our provider services, and the large majority of staff sit within there. As you can expect, because these are, they're really important roles, but they're not well recompensed. So we tend to find there's high turnover. What you will find is what you're seeing there is a snapshot in time. We always have rolling recruitment, and where needed to, if we need to bolster services, we will bring agency staff in. But equally, recruiting and retaining really good people is a key element there. On co-production of certainly of care plans, we absolutely encourage that within our frontline staff. With co-production of services, I think we've got some way to go there. And that's something which I've referenced by saying with our market position statement and with our commissioning strategies, I would want to be addressing that. So when we bring forward those strategies, there will be an opportunity for you then to challenge us and comment on that. So I would say that would be something that we would be bringing forward. On the white paper or the social care idiot's guide, for want of a better word, what we don't have, and we haven't had in Northamptonshire, is one, a clear statement about what adult social care is and how it will support people. And in every local authority where I've had to develop our adult social care offer type document. And I think that's something, again, which I would want not just to bring to you, but to be co-producing with people that use our services and with our providers to say what that is. So that is on my list of to-dos moving forward, and would be something that I would want to bring to this group. I think that's covered all the questions, at least giving you an initial answer, but recognising that this group will have a lot more focus on that.
Sorry, Chair. Just on the use of technology, David.
Oh, yeah. So we do. So our therapy service takes the lead on technology. So that is one, functional equipment, but also two, exploration of assistive technology. You may recall that I did make reference to us needing to have an assistive technology strategy. So again, that's something which I think needs to be brought forward. We do use sensors. We do have call alarm systems. We do use activity monitoring devices, but do we use them consistently? Do we have a clear strategy saying how we will develop in that area? Have we considered using devices which are publicly available to support people to remain well? So you know, I've got an Apple Watch which tells me how active I am and things like that, and there are devices that could be used and connected to our systems to help us understand what people are or aren't doing as well. So absolutely we do it, but I feel we need to bring forward a strategy to really set out what our ambitions are in that space over the next 3 years or so. It is a hosted service as well, delivered by West, so we effectively commission that service from them at the moment.
Thanks, David. Lucy?
Just a very quick one to say, I've pinged round a quick King's Fund explainer about what ICSs are, just based on the last white paper. So I don't think David and I have probably got all the answers yet. We'll obviously, I'm sure, revisit it here, but it does give a bit of a basic overview about what the white paper suggests. And then David and I hopefully will come back and talk about what it means locally, as and when we've got some more of the answers ourselves. But just to flag as well, I actually think I'm on annual leave for our next meeting. Helen, you and I obviously will take what that means offline, but just to send apologies in advance to everybody else.
Yeah, it's worth realising that there has been a year of other authorities doing ICS, and there's some good practice out there that's worth looking at.
We're also not starting from a blank page as well, so particularly our ways of working are quite consistent with ICS's. So we've had a Northamptonshire Health and Care Partnership Board, which has probably been undertaking significant elements of those functions. It's more about how do we reorganise, make sure that we've got the statutory body in place, but then are really clear about the new partnership, ICS partnership arrangements, what that means to Northamptonshire moving forward.
Well, thank you so much, everybody. I think that was a superb first meeting. I think what we can see from that is the huge amount of interest and energy that everybody in this group has. And I think we're going to do some really good things. If any of you have things that you want to feed in following this meeting, please, by all means, email me. And obviously, I'm going to be closely working with David and Lucy to help to develop this program. And I really look forward to your comments next time. And remember, this is your meeting, this is your group. So if we're putting things into that you don't like or you disagree with, say so. But feed in as much as you like. And sorry, over to David.
Sorry, it was just a really quick one. Councillor McGee, you suggested that there wasn't much time to really get the questions for the ICS discussion. What I would say is if you've got particular points that you would like us to cover when we come to the next meeting, please circulate those in advance, and we'll try and make sure that any presentation that we do, any paper that we bring, covers those off. So perhaps that would deal with some of your concerns in that space.
I think that's really important, that this isn't just about the actual meeting we have. The more we're communicating and getting this right, the better. So I really look forward to carrying on working with you all. I'm sure you're going to help us to make sure that we deliver the best possible services for our members of our public. So thanks so much. And I know I'll hear from you in between times, but if not, I will see you again on the 23rd of July. Thank you very much, everyone.
Thank you.
Bye-bye now.